All right, good afternoon. I'm Chris Moreland. On behalf of Rayner Intraocular Lens, I'd like to welcome you to this ESCRS Satellite Symposium that is a global discussion on premium monofocal IOLs. And the program today is a little bit different from a traditional symposium in that it is going to be a discussion. And our panel today is, I can't see the slides right now, but to my left, Gerard Alfarth, professor at University of Heidelberg. Alain Barsam, who is remote from London with Ophthalmic Consultants of London. Lucio Barato to my left of Camo in Milano. Manuel Dominguez, closest to me, who's chair at Hospital de Luz in Portugal. Carl Sunseifer is joining us from North Carolina this morning. And Alistair Stewart, also London remote. And together, we're going to tell you a little bit more about Rayner's EMV, Ray1 EMV intraocular lens, and talk about premium monofocal vision. Okay, so first off, we want to start with a presentation by Alain Barsam, who's going to talk to you a bit about the concept of the EMV IOL and detail some initial results that we've put together for you. Alain?
Thanks very much, Chris. Can you hear me?
Yes.
I'm just going to talk to you a little bit about the background to the Ray1 EMV. I will talk to you a bit about lens nomenclature, which I think is quite helpful, so that we're kind of on the same page with what kind of lens this is, how we would define it, and how we might compare it to other lenses in the market, which I think will be helpful for the discussion. I'm going to just share some of my own results based on over 150 implantations for the Ray1 EMV. And then I think we'll move on to kind of panel discussion after that. I mean, it is supposed to be unscripted. So basically, the terminology with respect to premium lenses has become quite confusing, I think, over the last few years, just because there's so many different lenses available. And I think it's important that we talk about what the lens does and how the lens works, rather than trying to define lenses into various categories that don't really fit anymore. So this lens would be just defined as an increased range of focus lens. I mean, it's a premium monofocal, but it does give you an increased range of focus compared to what would be a standard lens. And the mechanism of action is by the induction of very small amounts of spherical aberration. The principles of spherical aberration have been well established in laser refractive surgery, and now the lens technology is really evolved in order to try and take advantage of that. I was using the iHance as my premium monofocal prior to the Ray1 EMV becoming available, and I was a little bit disappointed with the amount of near or intermediate vision, which they did sometimes and often sometimes did not get. So it's quite nice to have this option, which gives a greater range of focus. The Rayner will tell you that it's about 2.25 diopters of increased range of focus if you target -1. Which really means that there's about a diopter to a diopter and a quarter of increased range of focus if you're targeting emmetropia. And essentially, in terms of my results, it performs, in terms of the distance visual acuity and the refractive accuracy, it performs exactly like you would expect a monofocal to perform. So we're seeing 78% of patients within plus or minus a half of target, and 97% of patients within plus or minus 1 of target. The patients that fall off target a little bit tend to be a bit myopic, which might be how they accept the refraction, because the patients will have some aberrations. So the myopia, I think it picks up more refraction in these patients, but it doesn't correlate with a reduction in visual acuity. And the monocular uncorrected distance visual acuity is 20/30 or better in over 90% of patients, and 20/25 or better in over 70% of patients, with over half of patients 20/20 or better. So it performs very similar to how monofocal lens would perform in terms of the distance vision. There's no complaints of dysphotopsia or anything of that nature. The uncorrected near vision is, I think, where the most surprising results are. So despite maintaining all the things you'd want from distance vision, we're seeing in one eye only, over 90% of patients at N12 or better, and 60% of patients at N8 or better, with some patients, about a third of patients being N6 or better, which is like J2 or J3. So, and then monocularly, where you account for summation, the results are even better than that. So N10 or better in 95% of patients. Um, so, in summary, this is a new, exciting premium monofocal lens with an increased range of focus. I've used it in many places. This is the stand. I very rarely use a standing monofocal lens, to be honest. I use this lens in everyone in whom I wouldn't use a trifocal lens or in whom I'd only use a toric lens. The only exception to that being patients that have already got high amounts of positive spherical aberration, such as patients that have had previous radial keratotomy or kind of old-fashioned, very high myopic laser refractive corrections. That's it.
All right, thank you, Alon. So that is a jumping off point to ask the rest of the panel. We'll start with Alistair Stewart. So how do you use the EMV in your practice today?
The results, although my numbers are small, have been superb. So it's commonplace for the distance eye to be able to read N8 or better, and it's commonplace for the reading eye to read 2063, 2050. So that's much, much better than what you'd expect with a standard monofocal. And it's that allows the patient to have summation between the two eyes, and it gets round all the caveats of standard monovision, just like Presbyon does. So my data is still anecdotal because there aren't enough of them, but I'm really, really pleased and think that it's going to be really promising to continue with this as the way I am.
Okay, thanks, Alistair. Dr. Barato, do you want to chime in about how you use the EMV IOL?
I started implanting multifocal IOL many years ago. It was 96 with a 3M IOL, 7 millimeter PMMA, and as you can imagine, the result wasn't so good. With the new century, we had much better IOL like Allergan and so on. And those lenses were improving and improving and improving. But in my opinion, after more than 20 years on multifocal experience, we don't have really a multifocal IOL giving 100% satisfaction to the surgeon and to the doctor, to the patient. In my experience, there are 4-5% of patients with multifocal that are unhappy. Some of them are asking for explantation, and this is not good especially for a private surgeon like I am. So when we started implanting this new generation IOL, not multifocal, not monofocal, I would say halfway, but it's not halfway, the result was much better. Our patients are not complaining, first of all. The vision they give those lenses is very good. And especially very important because they give intermediate vision, and we mainly aim for light monovision 0.5, 0.75. And in this way, also this patient can really have a good vision for near. So generally speaking, all my patients implanted till today are very happy, and also myself, I'm very happy with that. So the idea is continue to implant this lens. I only complain because we don't have the toric IOL, because we lose a lot of patients for those opportunity of implanting this kind of lens. But the quality of vision is very good. The patient don't complain about the night halos or starburst, etc. So I'm very positive about that.
Great, thank you. How about we go now to North Carolina and to Dr. Stonecipher.
Hey, thanks for having me. And realistically, I've had the opportunity to start using this lens since about June, late June, and primarily we abandoned really all the monofocals. So primarily, again, like Lucio was commenting, it's not available in a toric. So we're still using eye-enhance for our toric options. An eye-enhance will give me about -0.5 a defocus. I think this lens for me, if I've got a plano target, is about -0.8, 0.85, kind of like what Alistair was talking about. And then this is a nice lens for us because if you've never done monovision, we can do a mild defocus and they get that blended vision and they end up like they've described, being able to see their computer, they're able to see their phones, they can still cook and do a lot of those things that are extremely happy patients. I just did a patient's second eye yesterday. He's one of my referring optometrist father and he can't stop talking about it. And this is a guy that doesn't do monovision. And we defocused him about -1 just because his son was saying, hey, this is what my dad does. And he's really functioning at distance and near and extremely happy. One of the things that I would tell you, everybody with a new lens always tries to go out running with blazing guns. I think you want to start off with your virgin eyes. You know, people that have normal corneas, I think you ought to look at their spherical aberration, their Q values beforehand. That's my opinion. I know a lot of people in Europe don't have access to topographers, but I think it's a great lens. The modulation transfer function on this lens is like a monofocal. They see excellent at distance. The contrast vision is there, and we've been extremely happy with it.
Thank you. Dr. Dominguez?
Well, I started this lens when the pandemic started. So I had a lot of time to think about. So before, I used monofocals in 60% of my patients doing phaco. The rest, it was all trifocals. So the patient who has dysphotopsia, the patient who is not happy, I have some. So we have a problem. And it was a time when I could use this lens as a monofocal patient. So I started using the monovision system that Dr. Barrett told us. So I was starting with an offset of 0.5, then 0.75, and one diopter between those highs. Not so more than this anisometropia. Because I was surprised of the intermediate good vision patients gave us there in the reading charts. They said that they could read in computers and iPhones. Of course, at first I start with taller patients with big arms. I choose the dominant eye to get minus 0.5 diopter and the non-dominant with minus 1.25. It was my gold standard with this lens. And I start having patients with this refraction getting 1.2 at far. Oh, amazing. And Jaeger 2, Jaeger 3 at near. Okay, it was a good surprise for us. And no one talked about dysphotopsia. So with more than 600 lenses within this year, I can say that I would use monofocals when I need toric lens, monofocals, because we don't have toric. And the cost is a problem for the patient, or maybe when some spherical aberration is too high, I don't want to increase it more, so I would go on the classic monofocal. So otherwise, I would choose this lens.
And last but not least, Professor Alfarth, and you
Yes.
are a more recent user.
When I heard about the EMV, what I did is that I changed completely my stock of Ray 1 lenses to the EMV version. And for me, it's kind of the new normal, so to say, where I use it as a standard monofocal lens in patients, even if they don't ask for specific refractive treatment. Yeah, patients who have slightly macular changes or have some well-controlled glaucoma, I don't think it's any problem. They still may benefit from it. I started, first of all, to go for emmetropia, and it's quite interesting. I have some patients, even with both bilateral emmetropic, get to like 0.5 near acuity, which is already sufficient to get some decent near out of it. I'm now exploring to go further in terms of starting like half a diopter offset. And with that, I don't have any negative impact at all. It gets some extra, something like 1.5 to 1.75 defocus. And at the end of this journey, so to say, if I really have a patient that is specifically asking for a refractive outcome. And a lot of patients that come to me actually are pretty well informed. They know about diffractive technology. They come to us and say, I don't want a lens with rings or something like this. Yeah, they search the internet and get some terms somehow. So it's a good alternative I can offer them, which is quite obvious for them. So I'm still on the journey, but I'm really getting closer to the point where I'm getting to the point to have a full, it's not a modern vision, it's a kind of complementary system in terms of having both of best worlds, lower amounts of dysphotopsia and still a good depth of focus with minimizing risk. I think it's clever to look into aberrations. Years, companies were forcing us to reduce aberrations. Aberration is something bad. And in a way it's true because it makes a little bit lower vision, but on the other hand, you can use it to get more depth of focus. So you can play with that and balance it out. And that's a very good approach.
Okay, thank you. It brings up, yeah, go ahead, Lucio.
Which criteria do you use for implanting those lenses? I mean, for multifocal, we don't need to have a dry eye, no aberration in the cornea, not a bad macula, etc. What about this lens? Are you more open to say to implant?
Yeah, you can be completely open with that because we're still talking about, in a way, on a monofocal plus or enhanced monofocal. Dry eye you can treat, and if you have this kind of lens, patient can tolerate that until you guide them through the process of treating the surface disease, and still you can get something out of it. So dry eye is not a contraindication.
And what about the pupil size? Do they perform better with a small pupil, large pupil?
It is pretty pupil independent, actually, the EMV, which is quite good. Yeah, so you're not really getting into making a pupillometry in every patient you put that lens in, yeah, unless you have a synechia or whatever. It's a different story. But this is pretty pupil independent, so I'm not worried about that. About corneal aberrations, of course, we have to do like a pentacam or something, see if there are some funny corneas, post-LASIK or something like this. You have to look into that. Otherwise, but still, otherwise you would have a normal performance of a monofocal lens.
You do a lot of studies on the quality of vision on the optical bench. How do they perform on that?
Well, you can clearly see that you can extend the depth of focus up to 2.5, 2.25. If you do a defocus of one diopter, you get pretty good United Air Force target images, which gives you a very clear idea how far you can go. But you have to be careful that you don't overdo it. Yeah, if you do like 1.5 to 2 diopters, you get a certain effect on dysphotopsia, which you should not go so far. Yeah.
Hey, Chris, I'd like to chime in on that. It's Carl Stonesider here in Greensboro. Lucio, I think the one you want to add to that is myopic LASIK too. I think if we're gonna, have a positive spherical aberration lens, and we're, I know the periphery's, negative, but I think that the myopic LASIK patient, like Alan was talking about, the severe RK patient that we see still a lot of in the United States, they did great. The thing that I've looked at in our benchtop, looking at our defocus curves on this lens, is it's just like a monofocal lens. We're getting great contrast sensitivity, and we're also seeing that it's outperforming those, trifocality lenses that we use in the U.S., like Synergy and the Panoptics, in terms of their best vision at distance, for sure.
Alistair, Alon, any comments there? You're on mute, Alon.
So, can you hear me now?
Yep.
Yeah.
Yeah, I think obviously when you push monovision, you can get a lot more out of this lens. But I think one of the things that I've found, and obviously there are patients where you might exclude them from having a trifocal for a variety of reasons, like a poor ocular surface where it's fine to use this lens, for example. But what I really love about this lens is that patients don't really have to give up anything in order to gain a lot from having this lens. And it's totally fine to plan for a bilateral emmetropic target. In fact, what I tend to do often is I'll aim for the lowest positive number on the recommended A constant in the dominant eye and the lowest negative number in terms of the intended refractive outcome on the non-dominant eye. So, for example, a typical patient might have an expected refractive outcome of +0.1 in the dominant eye and 2.5, something like that in a non-dominant eye. It requires no chair time. So I don't need to tell them anything in terms of dystotopsia, in terms of adaptation or anything like that. And it requires no chair time afterwards because they come back and they're great. And, you know, essentially, obviously, they have to pay for the lens because it's a premium lens, but they are gaining in terms of quality of vision with respect to their range of focus. Because in my opinion, quality of vision that only gives you vision at infinity distance is not good quality vision. They miss out everything in the intermediate world. And this lens all but guarantees intermediate vision. And for some of them, they may even have some social reading. So, you know, you can just, I don't understand why anyone like wouldn't use this lens all the time, unless you want to use, unless you need to use an astigmatism correcting toric lens, or you want to use a trifocal lens. I mean, even for a non-premium lens surgeon, I think this lens, you know, represents a very easy way to jump into the world of premium lenses, benefiting patients enormously.
What would you do in a higher myopic patient compared, for example, to ametropic or hyperopic? What would your strategy there?
No, I don't change my strategy at all. And in fact, one of the things I love about this is that I found that the Technis Eye-Enhance, it really didn't perform well in the high myopes. You know, it performed better when you were using the higher power lenses. And with the kind of lower power lenses, we weren't seeing kind of results of any improvement really in intermediate or near vision. This lens, I've not seen a subgroup analysis yet, because the actual 150 patient analysis was only completed last night. So I've really only just laid eyes on it recently. But I'd like to look at the subgroup analysis of like, is there a discrimination between the low power lenses compared to these lenses? I don't think there is. Obviously, if they're very highly myopic, this lens I think only comes in at +8 as the lowest power. So then you don't have the option of using this lens at the moment, but maybe Rayner will extend the range at some point in the future.
Just to add to that, Alan, I think that's particularly important because the photocolouration qualities of the lens will change across the dioptric range. The induction of photocolouration has to be different at the ends of the spectrum. So it would be really interesting to see how much depth of field it induces at those different ranges, 100%.
Somebody has experience with implantation with angle kappa? We say more than 0.4.
I placed it in people with high as the other day. I had 1.8. Have not had any complaints at all. The pupil on that person was around a 4, dilated out to a 6, mesopic night vision kind of thing, scotopic. And so I have yet, I'm kind of like Alan and Alistair, we were talking a little bit before. You know, this is really my go-to lens for people that have 0.75 diopters or less of astigmatism. And so far, it's been extremely good. The dry patients, because that accounts for about 33% of my practice or more, because I just see a lot of that. They have been treated post-operatively, kind of like Gerard was talking about, and doing extremely well without those similar kind of complaints that we were seeing maybe in a patient that we put a Vivity in. Obviously, the trifocals, we don't really use those in the really dry patients for sure, but they're getting a lot of near, and I have seen what you guys are talking about in the lower dioptric powers. They don't get quite as much near vision with the Eye-Enhance. I agree.
So going back to a comment that Professor Alfarth made earlier about patient expectations, is it, in sort of going around Europe and the US, is it more common now in Europe for patients to come in and have done a reasonable amount of research and say, I don't want this or I don't want that? And is that a reason to go to more of a premium monofocal, enhanced monofocal, because you're able to meet those expectations a bit better? And maybe Lucio, I don't know who wants to answer that question first.
There we have more and more patients who are not cataract patients coming for presbyopia correction. It's not really my preferred surgery, but the request is very strong. I mean, and with this lens, I feel much more comfortable than on the past, I must say. So patients around 50, 52 with clear lens, they can have a good vision for near. They are independent from glasses. They can do all sports. They can go to the restaurant without any problem. They can go to the office, watch the computer without using their glasses. Satisfaction is very, very nice. I mean, we have to select also the right patient also for that. I mean, it's very important. So patient selection is very, 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 always very important, in my opinion.
Dr. Manuel?
Yeah, answering from the subsect of myopic eyes, actually I performed 4 lenses of 10. It's the minimum power 10 I got in this lens. But the patient needed a 7 or a 6, I don't know. But then it got -2 and -1.5. And the dominant eye, yeah, I had to perform PRK. And then it was a lady, she got wonderful for computer vision, and she expressed that she needed to drive a lot, and then she got with -5 in the dominant and -1.75 in the non-dominant, but that anisometropic took very, very well, and she's
Happy?
very happy.
Alain or Alistair, I mean, Carl, and then maybe you can speak after that, because I know in the US it's a lot more patient-driven than over here in Europe. But Alain and Alistair, what's your experience been?
One of my theories here is that when I'm doing lens surgery for this kind of indication, back in my mind, I want to avoid a lens exchange at all costs. So I think I'm thinking of, if you've got diffractive optic trifocal lenses and you've got patients that are dissatisfied, what can you do for that patient? That's where the patient selection comes in. Whereas if you've got the way the EMV works, any sort of problems that they have with night vision or problems they have with tolerance induced by the modified monovision, it's correctable with a pair of glasses. And I'll explain that to patients, that if you have tolerance issues, we can balance it with a pair of glasses. And it's always the underselling and overachieving, but it's giving them a way out that essentially has no risk. So that's why I'm so comfortable with this platform, is because if they are someone that doesn't tolerate it, they've got a viable option that's no risk to get rid of those symptoms.
Yep. Thank you. We actually have a question in the audience here.
Thanks very much. A question for the whole panel, actually. How does this lens compare with the Vivity lens? Because it seems to me the Vivity is also a really good option just for standard patients.
Carl?
I'll be happy to take that.
Yep.
We have a lot of experience with the Vivity. We started putting it back in July. I think you're finding a lot of the American surgeons are kind of like Alan was hinting towards earlier. This is a good lens, the EMV, to get into the marketplace for a lot of the surgeons that feel uncomfortable getting into reading style options. The Vivity for me is doing about a -0.75 in terms of reading, but we've had really good success, even in eyes that have had dryness and in eyes that have had other retinal kind of issues. So I think it's been a very forgiving lens. I think that the MTF on the EMV is a little bit better than that on the Vivity, but they're both equally effective. And I use, like on a day, if I'll do 10 premium surgeries, probably 4 of them will be Vivity. The rate limiting step, the only thing that I have with EMV is it's not toric. And so if it's above a 0.75, I'll probably start thinking about something different. And I just want to mention the thing that Lucio was talking about. We started doing refractive lensectomies back in the 90s because Yanni Plikris kind of said, hey, it's better than anything else we've got. So if you've got that we're trying to enroll for a current hyperopic study for LASIK, and it's really hard because of the protocol that the US FDA has put together. So a lot of those people have been converted to refractive lensectomies, 2 of which have gotten Rayner lenses. And the biggest thing about them, Lucio, is they have, this angle kappa, cord mu, whatever, that's way off. And I'm not going to put a Vivity in somebody like that, and I'm not going to put in a trifocal with somebody like that. So that's where this Rayner EMV comes into the sweet spot. So I think there are a lot of patients that the Rayner has allowed us to do a lot more with and make them happy without creating some of these dysphotopsias.
I see we have a similar experience.
Any other comments from the panel on EMV versus Vivity?
Well, one thing I also have to mention is we didn't talk about that, but the pure design of the lens in terms of the haptics, the resistance of the haptics inside the capsular bag against decentration and stuff like this, and the material is also a big plus for the lens. Yeah, we have to mention that also because it's not really for granted that you have always excellent optical quality, good material that doesn't degenerate, and things like this, especially in this kind of topic, and also that the lens is tolerant against decentration or tilt or something like this, which we will see with the EMV as well.
Okay, thank you. Question, mic number 1.
Hello, thank you for the discussion, very valuable information. I have a question about the eye hands. So the hospital in which I'm a resident at, I've seen this multiple times and the other surgeons confirm that after inserting the IOL, the haptics don't sometimes detach from the main lens. Recent experience I had was that we were waiting for 5 minutes for them to detach, and it seemed that nothing we did helped. We just had to wait. So why is that? Is it a factory error, or is it something to do with how we prepare the lens?
I got
No,
this.
the haptics are really sticky.
Yeah.
So what Gerard, I'm sorry, I didn't mean to talk over you. The haptics are very sticky. They added that when they were changing up the toric. So in the US, they were getting a lot of challenges with the rotation of the toric. So they decided they would change up the haptic to make it a bit more sticky on the ends. You know, we use a capsulorhexis forceps and just squeeze it so you don't have to sit there and wait for it to disengage. Gerard, I know you've talked about this before. What are your pearls with that?
Well, the thing is, it's not only that. That is the next thing that comes in addition. Before that, already the eye hands of the previous models had this so-called, we call it handshaking a problem when you implant the lens. And this also has to do how the lens sits in the injector, is prepared in the injector, and when it's pressed through the nostril of the cartridge, these things are compressed together. So it's also a kind of manufacturing thing in terms of what kind of injector they use. Yeah, and injector is a difficult topic. There's so many patents on it. You cannot just do whatever you want if you, as a big company. So they changed it to the simplicity, which is called this injector, but still like 25 to 30% of the lenses coming out with the eye hands or with the Technis have this handshaking procedure. I usually just take the bimanual irrigation aspiration and then manipulate on it, and so I get it open. Yeah, I never really waited 5 minutes and looked at it, but if you manipulate with the bimanual irrigation aspect, you get it open.
Okay, thank you.
Thanks.
Thank you. Yep, go ahead, Vasek.
Thank you. So I have a question regarding the monovision. So I know it's a very slight monovision. The offset is approximately 1 diopters, but still it's monovision, and we know that some patients cannot handle it. So these are apparently cataract patients, so you can't do a contact lens trial beforehand. So what is your opinion? You just inform the patient and say, maybe you can't get along with it, then I will do a PRK over, or what do you do?
I'm happy to field that. So again, the reason that the tolerance will be better is because of the show collaboration induction. So our work with Presbyon has shown that the tolerance when you induce show collaboration into the monovision to make modified monovision, tolerance is about 98% compared to 60% with standard monovision. But again, I will counsel patients that it is reversible. So you can dial down the anisometropia using laser or using glasses, however you want. But you're right that the difficulty you face is that you cannot trial these patients prior if you've got pre-existing cataract. You can do it if you've got clear lens patients. But the point is it is reversible. That is what I counsel patients about.
The other advantage of monovision is also it's reversible. It's functionally reversible as well. So if they're having problems with night vision, if you're using a Vivity lens or a trifocal lens or something like that, they're stuck with those quality of vision issues. Whereas with this lens, if you push monovision and you just give them a pair of glasses for nighttime driving, it's problem solved. So, I don't if I do use monovision, I'm happy to use it with this lens. I use monovision when a trifocal isn't indicated. You can use this lens really well without having to push monovision, but obviously if you want really good, guaranteed, unaided reading vision, then you do have to push an element of monovision in what you perceive to be the non-dominant eye, and obviously there's no way of knowing for sure if you've got asymmetric cataract.
Another thing is if a patient is so thick cataract that he cannot do a contact lens trial, then he will be happy anyhow when you do the surgery. And if there's like half a diopter of offset, he may not really have a problem with that. Unless you're talking about a real refractive lens exchange patient, it's a different story, but then you can do the monovision comparison. So I wouldn't worry so much about a severe cataract patient. They will be happy with it.
And when we do implant the monofocal IOLs, the monovision is a little bit stronger than the one that we can look for when we implant these lenses. We are looking for half an diopter of 0.75, maximum 1 diopter. It's very well tolerated about that. If we implant a monofocal, it's different because we need at least 150 or more on that. In that situation, it's good to try the contact lens first to see if the patient can tolerate it.
Anyway, if you get the patient with minus 0.5 and the other eye minus 0.75, this patient can read Jaeger 3 and he can see 0.9 or 1.0. If he has cataract, he's very, very happy because he can eat, cook, read even newspaper with good light, and it's a plus as a monofocal. But you have 1.5 in plus you give the patient for a year.
Yeah, I think that's an excellent point. We all talk about extended depth of focus and extended depth of field. And some of the new nomenclatures, really we're increasing the range of vision. And so I think when you start talking about depth of focus or depth of field to a patient, they don't have any idea what you're talking about. If you say, I'm going to extend your range of vision, in North Carolina, we have a lot of hunters and fishermen and all that sort of stuff. And so I say, I'm going to allow you to work, you know, early in the morning when you're going out to hunt in the field, or, you know, when you're standing in the stream and you're trying to tie your lure back on your line. It's a real big help to them, even if it's just a mild defocal if it's minus 0.75, and the patient's very happy. I mean, I always call the perfect refraction somewhere between minus 0.75 and minus 1. If they have that coming into the play, you know, those are patients you have to work really hard to make happy because they can pretty much see all around other than the cataracts now bother them.
Yes, I had a hunter that he told me that Dan is better in the competition. He's
better with an EMV.
Because he can focus far near, intermediate, and at far. So I have good, it's a good option for hunters.
Yes, question?
It sounds like it's a flawless lens. Are there patients you would never implant this lens to?
No, just a monofocal, as contraindicated. Or of course, eye aberrations and maybe RKs or retinal disease is the same as monofocal. You have the same problems as the monofocals.
To build on that, I would say be too careful in post-LASIK patients or anyone that's had refractive surgery. I think we were talking about it before we came online, that if you are going to move the dial of scope aberration, you need to know what they're bringing to the table. So if you've got someone that's had refractive surgery before and potentially has already got quite a high level of scope aberration, you need to be looking at that. If you're looking at virgin eyes, you're kind of, you know, you're almost in a very, very safe position there. I would just be cautious with the post-LASIK patients.
Alon, were you going to say something?
Well, I was going to say I don't use it in patients that I've got zonulopathy. So if I'm worried about the lens decentering, I mean, it is a very forgiving lens. I've not had problems with angle kappa, but I mean, because it is a spherical aberration principle, I would be concerned about a significant decentration in terms of quality of vision. So if I know the patient has pseudoexfoliation syndrome or a history of blunt trauma or there's frank zonular problems, then in those patients I would use a standard monofocal lens. And then I agree with what Alistair said with respect to previous refractive patients. But otherwise, you really can just use it in everyone. I mean, it really is a lens where I think I think your average cataract surgeon has to ask themselves, why would they not use this lens? Because there really aren't many reasons, in my opinion.
Yeah, and if somebody wants a number, for us, it's somewhere between 0.35 and 0.4 in terms of their spherical aberration. Once you get above that level, you start getting a little pushback from the patient with regards to contrast sensitivity and some other issues.
That brings up a question. Carl, you had mentioned earlier about need for corneal topography or pentacam, and I think Alan has said this too. For practices, for a surgeon who doesn't have access to that technology, your recommendation is to use the EMV regardless because it's relatively forgiving?
I think it's a great forgiving lens, but if I don't have a topographer, then I'm not going to do, anybody that's had previous refractive surgery, I'm kind of like Alan, if they have, pseudoexfoliations or some other zonulopathy, I'm going to do it in my easy peasy lemon squeezies, as I say, that the simple patient, because I really want to know where they are. Because I think if you're pushing, their spherical aberration or two, you're going to run into issues with this lens. But it's a very forgiving lens. I have yet to have a patient, that says, oh my gosh, I want it out because of this, that, or the other reason. I just really haven't seen that. But just for now, whenever I'm starting off with a lens and I'm recommending it to my fellow colleagues, stay in that sweet spot, people that haven't had issues before, and start with those. And the other thing that I want to say about this lens is when you're done refracting it, it's going to end up a little minus. So when you're going back to look at your A constants, don't get all freaked out if your retinologist or your refractionist, is getting a little minus on this lens. These lenses are a little bit different to refract, and they're definitely different with a autorefractor. So those that use autorefraction in their practice and their refractionists depend on that. It's going to be different, this lens. Anybody else have comments about that?
Yeah, I can confirm that, and I think it's also very important in your practice to train your technicians to really do first a binocular uncorrected vision evaluation. If the patient is happy with that, don't go and refract every eye individually and then kind of ask for a touch-up or something like this. Yeah, so the binocular outcome is the first thing to look at, uncorrected, and then you're fine. Yeah, it's a big mistake sometimes to go too deep in that and confuse patients.
Alan, Alistair?
Yeah, no, I agree with those comments. It's you to be honest, you don't need to have an optometrist, you don't need to have technicians, you don't need to have topographers. Obviously, all of us, we do a lot of premium lens surgery. We have all of this stuff in our practice, and we look at it, with quite a lot of detail. But you'd be totally fine to exclude certain patients based on history, and then just do biometry and put the lens in. You would be putting the patient at no risk to do that.
Alistair, do we have any questions from online audience that we want to bring up?
The chat is currently empty, Chris.
Okay. Okay, so at this stage, are there questions that any of the panel want to ask each other and regarding experience with premium monofocals, enhanced monofocals, whatever, however we describe these lenses? Okay, so in that case, I think it would be good to talk about how we define these lenses, because this is something that I think some other meetings earlier this year, there's been a discussion about renaming. We'd call it EDOF. Do we call them PC-IOLs? So for this class of new lenses, how do you describe them in your practice? How do you describe them to patients? And what is the best way, what is the best nomenclature on the way forward, do you think? Let's start with Professor Alfarth.
Well, that's difficult to say, but I liked the term of monofocal plus, yeah, or next-gen monofocal, or enhanced monofocal. It's also okay, but it's like company driven by one specific manufacturer. So to show that we have, on the one hand, the safety of a monofocal lens, but as a plus, an extra icing on the cake, and differentiate that from the more complex optic, like the trifocals, which are always inherited with some trade-offs. So I like to place it in these terms and explain that also to my patients.
Dr. Barato?
A final comment?
No comment? Stay away
I
from
want
that.
to give a final comment from my point of view.
Okay.
I implanted the first lens exactly 43 years ago. And in this 43 years, I was continuously looking for the perfect IOL for my patient. This lens is not the perfect IOL, but it's very close to what. I will say that it's the closest one at the moment.
And how do you describe it?
Please?
How do you describe it? Do you call it a premium monofocal? Is it, what is the term that you prefer?
No, this one.
He's not giving in. Dr. Dominguez?
It's a monofocal plus, monofocal premium, monofocal. That gives intermediate good vision.
Okay. Online team. So start with Dr. Stonecipher.
To my colleagues, I call it monofocal plus. I'm like Gerard. I like that term. It makes sense to me. To my patients, I say I'm going to extend your range of vision. I'm not going to promise that you're going to be glasses free. We don't charge extra for this lens. It's part of our second package. So for the most part, we don't have any issues with, they're paying extra money, so they're expecting a lot more out of it. To tell you a funny story, I had one of my optometrists the other day argue with the patient that you had to pay for a premium lens because you're reading so well. And then when the optometrist called him, I said, I'm really sorry. We just started putting this Rayner EMV in. You're going to hear about me talking, a lot more about it later and how we're using it in all these patients. And I think that's a big plus, especially for the referral population. A lot of patients are coming in requesting, this style of lens. They don't know really what it is. They just know that their family members and their friends are getting an extended range of vision that maybe their parent or somebody didn't get. So it's been really a boon to our practice.
Thanks, Carl. Alistair Lon?
Yeah, I think it varies in different countries in terms of how people are remunerated with respect to insurance companies, and a lot of insurance companies try and involve themselves in terms of how lenses are classified and what lenses you can and can't charge for. I'm not really sure what the situation is in the US, but in the UK, premium lens is something that you're not able to charge patients more for. And I think given that patients do get more for using this lens, and there's an expense to kind of using it, there's no reason that you shouldn't charge patients. So I kind of feel that the premium, so calling it a monofocal is a bit confusing because it does more than a monofocal. And I like the term increased range of focus. Increased range of focus would include the kind of traditional extended depth of focus lenses, which is also a confusing term, but it does give you more focus than monofocal. So I like the nomenclature of increased range of focus. ACOS did a survey of its membership and looked at some lenses. A nice article written in CRST by Shiraz Daya where he classifies, it proposes a new nomenclature for how lenses should be described. It would be good if everyone could adopt the same thing, so there isn't any confusion in terms of how you describe lenses.
Okay, thanks, Alon. Alistair, anything to add?
I think that it's been said, but I think something along the lines of modified monovision. I think it's important we're not deterring surgeons away from using it because of the fears of causing the problems that are somewhat associated with premium diffractive IOLs. Knowing that, as Alan has said, that you can get out of jail free card, you can give it, and you're not going to put the patient any harm, and it's all reversible. So I think something along the lines of modified monovision and modified monofocal.
Okay, we have a question from the audience.
Thanks. There seems to be a little bit of discrepancy on the panel as to what they're aiming for in the dominant eye. So I've heard some people say they're going for the first plus up to plus 0.3, and other people have said minus a half. So could maybe we just clarify what the ideal situation would be?
I use the dominant eye with from 0 to minus 0.5, minus 0.75, always negative.
Dr. Barato?
Sometimes we can use the dominant eye also for NER. I mean, it's not really mandatory to have the non-dominant eye for NER. Some patients who really use their dominant eye for NER, why not to put this lens a little myope and the other one, for example, metropic? I mean, we have to talk about that with the patient also. I mean, monovision is something very interesting, but it can be not in a fixed way. It should be open to patient expectation, patient needs.
Professor Alfarth?
Yeah, as you just said, you can individually look at the patient and also if he's hyperopic or myopic and then choose from which end you want to come closest to zero. And also the question is, you want to do some monovision and enhance the depth of focus, or you just use it as a normal monofocal lens and put emetropia, because then it's a different story. Yeah, it's not every patient who gets a Rayner EMV is a premium spectacle-free type of patient. Yeah, you can, as I said, you can use it also as a normal monofocal, and then I usually go closer to zero. If I have a hyperopic patient, I may choose a hyperopic refraction. If I have a myopic patient, rather than myopic. So you can do that as you like.
Thank you. Alistair, go with you.
So I think there, across the surgeons, there are, obviously, we all have a different approach to exactly what we aim for. I don't think that's specific to the EMV, depending on your A constants, what you've been trained to do. The thing about the EMV is it's forgiving because of the straight collaboration induction. If you're a little bit off target, either plus or minus, this lens will help you there. Because of that depth of field, patients won't notice if they're plus a half, minus half away from it. They'll still get good vision. But I generally try to get them as close to plano as possible for the distance eye.
Carl.
So it's real simple for me, and I hope I wasn't the one that started the confusion. So let's say if we're doing a plano target, Steve Schellhorn and his group just published in the JCRS article on that where should we leave people toric and where should we leave people spherical. And so what I was trying to imply is if you're trying to choose between a 0.15 plus and a 0.15 minus, I'm probably going to target a little bit plus, but I'm like Alistair that I want you plano in that dominant eye because I want you to see as best you can in that dominant eye. Whereas in past, I've always tended to lean towards the first minus. I think I'm probably going to lean towards the first plus depending on what the patient's requirements are. So if they're a pilot or a truck driver, I want them as close to plano as I can. But if I have to choose between 0.15 plus and 0.15 minus, I'm probably going to lean towards that plus side. Now, in terms of the monovision target, I think that depends on your hobbies and your habits. So I want to know what you're doing for fun and what you're doing for work. So if you're a truck driver who loves to tie fishing flies, you got a little bit of a challenge and you're going to have to tell these people, hey, I'm not going to get you out of glasses, but I'm going to get you less spectacle independent.
And Alan.
Yeah, I mean, I think that the discrepancy between defocus and spherical aberration, even on the most advanced aberrometers, has not been, worked out in a functional way as though we'd like to imagine. And I see it a bit as there being like a point of confusion, a little bit like we look at with respect to kind of the relationship between sphere and cylinder in terms of how the eye handles light. And what I find in my positive spherical aberration patients like this is that they do end up being a bit more myopic in refraction, and that's because of this kind of point of confusion. So by pushing plus a little bit in the refractive outcome, you can overcome that and maintain the best distance vision. So like Carl said, I would go for the lowest positive plus number in the dominant eye. And then in the non-dominant eye, I go for the lowest negative number. But again, it depends on what you promise the patient. If they really want reading vision, and you're treating them like a premium patient, and that's the priority, and they don't mind sacrificing a bit of distance vision, then you could push minus. But I think that in general, you don't want to sacrifice distance vision.
And I think you'll see that every speaker had a little bit of a nuance in how he's using the EMV, which is one of the points of the lens, is that the optic is fairly forgiving. And that enables you to meet the patient's needs perhaps more than you can with a standard monofocal or monovision treatment. We titled this symposium The New Standard of Care. So is there a point in time where a lens like the EMV becomes or a Vivity or an iHance becomes the standard monofocal treatment per se, and you're not using a typical, what we call traditional aspheric or spherical monofocal IOL.
Chris, I'm going to jump in and answer that real quick because I got to jump on an airplane to speak in New York, as you know.
Yes.
So primarily, I have switched my entire monofocal over to this. I'm kind of like Alan. Maybe there's a few rare exceptions, but maybe a highly hyperopic LASIK patient, that myopic patient who's had RK. I had one that had 80 some odd incisions the other day. Yeah, I counted them. Those kind of things we're going to be thinking of, maybe other lenses like an IC8 or some of these other things to try and diminish that. But I think this is my go-to lens, and I can't wait to get the toric in because I'm kind of like Lucio. There isn't the perfect lens out there, but this one's doing pretty darn good for me. And thank you for having me, guys. I gotta check it.
Thanks, Carl. And I've just been told we've gone 10 minutes over. So last remarks, Alon.
Yeah, I mean, I think the Rayner just need to bring out, the toric version is in the pipeline. It's going to be out within a few months. But I think that once the toric version of this comes out, once they push the range to get under plus 10 diopters, this lens, the adoption of this lens, the only reason people wouldn't adopt this lens, I think, is that they're just ignorant and don't know about it. So providing people kind of are aware of it, we all use it in slightly different contexts. But what we all have in common is that we don't have, unhappy patients. I've done 150 implantations. Many of them have been in refractive patients and only have to do one laser enhancement. So it's a great lens, and I think that people will just be hearing more and more about the EMV in the future.
Thank you, Alon. And Alistair.
Yeah, to echo Alan's sentiments there, that it's a great lens to use in terms of its forgivingness, and I think that's really where you can use it in so many different ways. As you see in the panel, is very different from wanting to use it in monovision to if you're just sorry to use the word, but a standard cataract surgeon, and you're just doing plano in both eyes, it's going to give you the patients a bonus on their reading. There are very few drawbacks to using it.
Great. Professor Alfarth, last words?
Well, I think we are at the beginning, actually, still of a new technology. And as you have seen in the panel, everybody has found its own approach to it. It may be quite interesting to have a similar panel next year and then see where did it bring us and what are the pearls that I have or he has or they have. Because I think we all together have a pretty good idea what we like to try. And I think it will come out in the next couple of months, the more we use the lens and the more we define the patient profiles here.
Dr. Barato? We're done. Manuel. Any other comments? No? All right. Well, thank you all very much. In London, Alon Barsam and Alistair Stewart, Professor Alfarth, Dr. Barato, Professor Dominguez. And thank you for your questions today. And if you have any further questions, you want any follow-up information about EMV, visit the Rayner.com website. We have the Plus1 EMV campaign, lots of videos, white papers, et cetera, and you can also connect with a Rayner representative. So thank you for attending today.
Thank you.